Well, thank you very much, Steve, and good evening, everybody. Thank you for coming. I hope we'll be able to give you some helpful information. By way of disclosure, I have worked as a consultant, a researcher, or a speaker for a number of companies that make treatments in this area over the last 35 years. I'm going to try and take an overview in the short time allowed of gastroesophageal reflux disease, which has been around for quite a long time. In this contemporary Rowlandson cartoon, you see the many ways in which reflux disease manifests itself and the wide variety of names that it attracted even as far back as 200 years ago. In normal circumstances, all of us have a little bit of reflux of acid from the stomach into the esophagus, particularly after meals. But we have a clear limitation to that. And the reason that the acid is seldom a problem in normal people is that the normal muscular activity of the esophagus sweeps it back into the stomach. And of course, we spend a fair amount of time standing up, which also helps through gravity. The small amount of acid that remains can usually be neutralized by saliva. In the cartoon on the right, you can see the various factors involved. Therefore, in people with reflux, there may be impairment of that clearance. It's more common in people who have a hiatal hernia because that acts as a reservoir for refluxing from the hiatal hernia. And there may be some weakness of the lower esophageal sphincter or muscle mechanism, which is the valve that separates the stomach from the esophagus. And the symptom that is characteristic of reflux is that of heartburn. There may also be regurgitation, but the diagnosis of heartburn alone doesn't necessarily tell us whether this is just acid going up into an esophagus that looks normal but is sensitive, or whether there is inflammation as a result of damage by the contents of the stomach eating away at the lower end of the esophagus. And in more recent years, some of you may have been aware of, or maybe even suffer from what is called NERD, or non-erosive reflux disease, where patients are symptomatic, but you have investigations with the telescope and you can't see anything there. Here you see some of the mucosal damage that we see through our endoscope or telescope when we look into the esophagus. And you can see here varying degrees of inflammation. The normal lining looks white in these pictures, and where you see the tongues of redness, that's the inflammation that occurs with esophagitis. And one of the concerns that has been discussed in academic communities is that there may be a continuum from having heartburn through to the extreme end of an esophageal cancer. And I show this only to tell you not to be concerned about this. This is very unlikely in you if you have reflux disease. There is an association, but it's only because of the very large number of people who suffer from heartburn. And in Canada, esophageal cancer has a very low incidence, around 2 per 100,000 of the population. So what about the epidemiology of this disease? There's almost an epidemic of reflux disease occurring around the world. And this is data from the United States, and you can see over the past 15 years or so in 2 studies that there has been an increase in the prevalence of this condition. And this is true in Western European countries, and it's now being seen in Asian countries where reflux disease was hardly mentioned at the time that I qualified as a physician. So this is on the increase, and it's probable that we're seeing an increase here in Canada, although we don't have our own figures. Some of this is also related to obesity, and the association between reflux disease and obesity is real. In obese patients, we know that acid reflux episodes are increased in number and in their duration, and that acid is in the esophagus more and for longer. So what do we know about reflux disease in Canada? Well, approximately 5 million Canadians report heartburn and or acid regurgitation at least once each week. Reflux patients miss work about 16% of each year, and this loses workforce productivity of 1.7 billion hours and costs about 21 billion Canadian dollars per year. Canadians received 12.4 million prescriptions for the proton pump inhibitors, probably our best treatments, in the year 2004. And almost half of GERD patients, despite that, are still dissatisfied with their treatment. Increasing age is a risk factor for developing the disease, although we're now seeing it much more in younger people. And moderate or severe symptoms of reflux disease and reflux indicate that this is a chronic disease and it lasts essentially for a lifetime. So what about the associated factors? Well, diet and lifestyle are clearly important, and there are foods that we know are associated with triggering or worsening the symptoms. Fats, peppermint, spearmint, which is strange because many people like to take that after a meal, chocolate, citrus fruit juices, coffee, cola beverages, onion and tomato juice. And it won't be true that these will affect everybody with GERD. Some people may have idiosyncratic reactions to or worsening to one thing but not another. There are a variety of drugs that doctors commonly use, like anticholinergics, beta-adrenergic agonists, calcium channel blocking drugs, and so on, which are used commonly in general practice, which may decrease that little valve at the bottom of the gullet. And there are the lifestyle issues of alcohol, smoking, and of course heartburn is common in pregnancy. We're increasingly aware of sleep disturbance, and identifying people with nighttime heartburn is important in order to try and time treatment properly. And anybody who has coughing or choking caused by acid or a bitter taste in the throat during the night, the people who get heartburn when they lie down, waken in the morning with heartburn or a sour taste in the mouth, or who actually are taking additional over-the-counter medications at night to prevent heartburn, all may be suffering from nighttime symptoms. So how do we approach this? Well, I usually think in terms of a cascade approach in the advice and self-management, the lifestyle measures, the control of weight, and the simple use of over-the-counter antacids or H2 receptor antagonists. We do not have PPIs over-the-counter in Canada as yet. Primary care doctors obviously want to exclude any risk factors like difficulty in swallowing, and they need to determine whether the patient has some kind of response to acid neutralization with antacids or acid lowering. If there is a partial response or a complete response, then this is acid reflux. If there's no response, your patient probably has functional heartburn, which is a separate condition. The lifestyle advice should always be emphasized by general practitioners, and of course prescribing the best acid-lowering drugs, which will be a PPI, which have to be taken correctly, and I'll point that out in just a moment. And then possible consideration for referral to a specialist if the patient's losing weight, has anemia, has difficulty in swallowing, for example. And at the specialist level, one's going to have specialists determine whether or not one needs to look with the endoscope or not, and one needs to separate other possible esophageal conditions and the possible need for surgery, which is relatively not necessary these days. Now, I did mention that a lot of patients are still dissatisfied that the symptoms are not completely controlled. And you'll see here that amongst 1,000 GERD patients, both the patients themselves or the physicians have around about a 35% dissatisfaction. And this is partly due to the limitations of the drugs which we actually use. And the first thing we should do then is to optimize the taking of those drugs. And the PPI should be taken half an hour before the first meal of the day. And you'll see that in a survey in the US, 36% of people did not get advice at the time of the PPI on dosing. And that's of physicians, primary care physicians. And in a study of patients who were started on PPI treatment, only 27%, a quarter of patients, dosed their PPI correctly. So this is a really important point. And only 9% actually dosed optimally. So this is an area where you can often improve the outcome. Now, lastly, there's been a lot written about these drugs in the popular press. This actually is from a newspaper in the United Kingdom, but we see the same thing in the Toronto Star or the Hamilton Spectator or whatever, and that is alerting the population that pills for heartburn may be risky to you and cause problems. I want to reassure you that this treatment is widely used and is generally safe. It's the second most commonly prescribed drug class. Many millions of patients have been treated around the world over the last 25 years. But, as with all medications, there is a potential for side effects in a small group of people, and these have to be weighed against the overall benefits which you're going to get from taking these drugs. And in my view, these treatments should not be denied to patients who will benefit from them, but of course we should use the lowest effective dose. Thank you very much.